Gallbladder cancer is the most common biliary tract malignancy, fifth most common in gastrointestinal tract. Many of these tumors are not resected at the time of the presentation. 5-year survival rate is less than 10% in most of the reported series. Incidental gallbladder cancer defined as gallbladder cancer diagnosed during or after cholecystectomy done for benign gallbladder disease. Incidental point to denote a histological surprise. Incidence range from 0.3% to 1%. Gallbladder cancer is suspected preoperatively in only 30% during surgery. 70% discovered incidentally by pathologists. Incidental gallbladder cancer is
So now this Anil, this data is Western data, no? 70% discovered incidentally.
Incidental gallbladder cancer is going to become a increasingly frequent. The widespread use of laparoscopic cholecystectomy has led discovery of incidental gallbladder cancer at an early stage. Because of early stage, increased long-term survival, significant increase in survival when compared with those who had a previous diagnosis. मतलब pre-operative diagnosis. Sorry, sir. Pre-operative classification of gallbladder cancer.
I didn't understand. Go back.
मैम pre-operative मैम जो पेशेंट डिटेक्ट होते हैं उसमें मैम इंसिडेंटल गॉलब्लैडर मैम जैसे लैब कोली मैम ज्यादा हो रहा है तो इंसिडेंटल गॉलब्लैडर
so that is driven by the stage of the gallbladder determines
classification of gallbladder cancer based on histology. Fundus region 60%, body 10%, neck body 30%, neck 10%. Adenocarcinoma is most common. Differentiated papillary intestinal type, pleomorphic giant cell, poorly differentiated, signet ring cell, mucinous, clear cell, colloid, choriocarcinoma, squamous cell carcinoma, adenosquamous. Mesenchymal type, embryonal, rhabdomyosarcoma, leiomyosarcoma, malignant fiber histiocytoma, angiosarcoma, others melanoma and carcinoid. Incident of gallbladder carcinoma variety 99%, in which adenocarcinoma 89.4%, papillary variety 5%, mucinous and mucin producing 5.3%, squamous cell carcinoma 1.8%, other 7.8%, sarcoma 0.2%, neuroendocrine 3%. Gallbladder cancer can be categorized into infiltrative, most common variety, nodular and papillary. Infiltrative tumor is spread in subserosal plane. Tumor seeding in peritoneum cavity can occur if subserosal plane is violated during and presence of tumor not recognized at the time of the polyp. Nodular or most harming, early invasion into gallbladder wall, into liver and other organs. Despite invasiveness, easier to control surgically than infiltrative form. Papillary variety, polypoid or cauliflower-like appearance, minimal invasion, prognosis is better. Investigation for restaging. Ultrasound, if you do ultrasound, ultrasound finding for early cancer, discontinuous mucosa, echogenic mucosa, submucosal equilucency, which is one and
so this is the restaging you are doing. So gallbladder is already out, na?
जी मैम, gallbladder is already out.
Then what are these discontinuous mucosa and echogenic mucosa? You are describing staging investigations for gallbladder cancer per se, not incidental then. So what is the normal thickness of a gallbladder?
1 to 3 mm. 1 to 3 mm.
And when do you say it is suspicious?
More than 3 mm.
Anatomically, which wall is absent in gallbladder?
Doppler assessment of blood flow in areas of mucosal abnormality differentiate early malignancy from benign lesion. Investigation CCT, CCT thorax, abdomen and pelvis. Local CCT local extent of disease and distal mets, regional and distant lymph node. Size more than n mm में 80% accuracy. 79% accurate for T1 versus T2.
क्या लिखा है? Size more than 1 MC क्या होता है भाई? तुमको मैंने बोला भी था इसको करेक्ट करने को. नहीं तो इसमें MC दिख रहा है?
सेंटीमीटर सर उल्टा मैंने लिख दिया. सेंटीमीटर, मोर देन 1 सेंटीमीटर. 1 सेंटीमीटर से बड़े जो लीजन होते हैं लिम्फ नोड के.
हाँ, इंग्लिश में बोलिए. You don't start speaking in Hindi.
No Hindi allowed. No Hindi allowed in seminar.
Yes.
And
lesion
even when you are presenting before an examiner, यहाँ पे हिंदी medium पे तो हो नहीं रहा है. You all must learn to speak only in English.
जी मैम,
English.
जी मैम,
Simple, straightforward English.
मैम.
Okay, continue please.
मैम MRI oblique MRCP, sensitivity for hepatic invasion 67%, vascular invasion 100%, CVD invasion 100%, and for lymph node 56%. Specificity for all these lesions near about 89%. PET CT indicated only when CT and MRI finding are equivocal. PET CT more accurate in diagnosing metastatic disease than CT. PET CT 100% sensitivity compared to 25% with CT alone to diagnose metastatic disease, especially occult metastasis. Lymph node sensitivity 57%, specificity 54%, both regional and distant metastatic node, especially occult node. PET CT altered surgical management near about 17 to 23% of the patient.
So when will you do a PET CT in an
Ma'am-
incidental gallbladder cancer? Or you will do it or you will not do it at all?
Ma'am, if information is not adequate from CT oblique MRI, basically early stage small lesion, ma'am, which is not pick up near about ma'am lymph node lesion.
So
less than
early stage lesion will show on PET scan. Will it be
Ma'am.
helpful?
Ma'am, lymph node less than 1 centimeter can be seen, ma'am.
Anil, incidental gallbladders will be usually early lesions only. Most of them will come as early lesions.
Sir.
You won't get T3 or T4. T3 also occasionally, T4 and all you won't know. You will not get on. They will not be incidentally detected. So will you do a PET scan in these, or you will not do a PET scan in these?
If sir CT and MRI finding is well enough, sir, local and distant site is.
See, Anil, the answer to this is what percentage of T1A, T1B, T2 gallbladder cancer metastasize?
T1A, sir, near about 3% lymph node mets in T1A, sir. In T2, sir, 15 to 25%.
T1B का क्या हुआ?
Sorry,
Where did it-
T1B 15 to 25%. T2, ma'am, near about 40%. T3 is 70 to 80%, and T4 is more than 85%.
Actually, you should say there are no clear-cut guidelines whether PET CT should be done, but if the tumor incidental cancer is about T2 or node positive or has any equivocal findings on routine scanning, a PET may be added to complement the findings.
Where is the advantage of PET over MRI or CT? So what is the advantage of
Sir,
PET?
in thoracic mets, sir, especially.
See, you're
Sir,
talking gallbladder cancer, beta.
Yes.
In a gallbladder cancer, what is the advantage of PET CT over CT or over MRI? You find maximum of your metastasis from gallbladder
Sir, hepatic and peritoneum, sir, basically.
and peritoneum.
Yes,
So
sir.
where is the advantage of PET CT over CT?
Sir, small lymph node lesions are doesn't picked up in CT and MRI, sir. Sir, PET CT resolution is 6 mm.
So it is basically the advantages in picking up the
and,
lymph nodes and the peritoneal reaction. Lung met you can pick up in a CT thorax.
Sir, serum tumor marker of minimal clinical value. CEA in presence of appropriate symptom near about right upper abdominal pain, jaundice, significant weight loss. If more than 4, 50% sensitivity and 93% specificity. CA19-9, more than 20 units.
What is the full form of CA in CA99?
CEA carcinoembryonic antigen, ma'am.
CA99 की पूछ रहे हैं.
CEA
What CA stands for in CA99?
antigen, ma'am. Patient with incidental gallbladder cancer can be divided into 2 clinical groups. Patient with gallbladder cancer discovered during cholecystectomy. Patient with gallbladder cancer diagnosed histopathologically after surgery. Incidental surgery. Intra-op staging done with the help of frozen section of gallbladder and lymph node. If found resectable, cholecystectomy in block hepatic resection plus lymphadenectomy plus minus bile duct excision if bile duct is involved. In unresectable cases, biopsy to be done and testing for MSI, MMR, tumor mutation burden testing, and following systemic chemotherapy. Incidental finding and pathology in T1A is on biopsy with negative cystic margin, and also other margin observe only cystic duct node positive, CT, MRI abdomen pelvis, chest CT, staging laparoscopy, microsatellite instability, MMR testing, considered neoadjuvant chemotherapy, hepatic resection, hepatinectomy, and T1B or greater, staging as previous CT, MRI abdomen pelvis chest CT, staging lab. If resectable, go for hepatic resection, lymphadenectomy, plus minus wild duct excision, and if unresectable, microsatellite instability, matrix mismatch repair testing, and systemic chemotherapy. Incidental gallbladder cancer, if operated in other site and expertise is not available, refer the patient to tertiary care cancer center. In higher center, review or biopsy by expert pathologists regarding T stage, cystic duct margin status, lymphovascular invasion, perinodal invasion, time interval between incidental gallbladder cancer detection and final surgery between 4 to 6 weeks.
Yeah, I don't agree with your last statement. Go back. Time interval between incidental GBC detection and final surgery is between 4 to 8 weeks. What is the meaning of this sentence?
Detection near, ma'am, after lab coli during pathological review of specimen, and patient referred from tertiary care center for final surgery.
Referred to.
Ji, ma'am.
So
this time interval, ma'am.
So this is the optimal, but is there any data to suggest that this time interval affects the outcome?
Ma'am, 4 to 8 week, after 4 to 8 week, ma'am, local recurrence and distal recurrence is increased, ma'am. This is study, ma'am.
Basically, the recommendation is it should be done as early as possible.
And further, there are studies to say that it is the biology of the disease and that is the stage of the cancer rather than the time interval. And it is especially important if incidental cholecystectomy, whatever you were doing in the primary surgery, had any difficult surgery leading to perforation and bile spillage. Those patients are at very high risk of developing recurrence. That is why there is emphasis on neoadjuvant chemotherapy even in incidental. So per se, time interval is not that important. Next, please.
You have to also remember, most of the laparoscopic surgeons don't bag their specimen. So what is bagging has to do with the spillage?
Sir, endo bag use after before removal of the gallbladder, and gallbladder contained in the bag, and then remove with the epigastric port.
Most of the surgeons will not be using the endo bags. Because why they don't use it? Because lab chole is being done as a package at a very low rate, and they try to cut cost to a minimum. That is why some of the steps which are necessary will not be done. And that is why in your area, the port site recurrence rate is very high.
The role of staging laparoscopy to identify radiologically occult disease, higher yielding locally advanced tumor, poorly differentiated, T3 or higher, margin positive. Compared with the early stage, yield is 25.2% versus 10.7%. Obviated need for laparotomy, 55.9%. Simple cholecystectomy for T1A tumors, or T1B and beyond, hepatic resection with regional lymphadenectomy plus minus wild duct excision. Re-excision because 56 to 60% had residual tumor in the liver and bile duct. Presence of residual tumor important predictor of survival. Hepatic resection. Hepatic resection for gallbladder cancer. Resect tumor that directly invaded the liver, prevent micrometastasis that may recur around gallbladder bed. Extended cholecystectomy or glean resection, cholecystectomy plus partial resection of liver, segment 4 and 5, approximate 2 to 3 centimeter from GB bed. Anatomical section of liver, segment 5 and lower part of segment 4, when gallbladder cancer invades the liver bed to a depth of 2 centimeter or more. Right hepatectomy, when gallbladder cancer invaded right Gleason capsule invasion of right portal, hepatic medicine, GV cancer, I am already discussed. Reoperation for incidental gallbladder cancer, R0 resection and clearance of locoregional lymph node resection, cystic lymph node, pericolidocal lymph node, periportal lymph node, hepatoduodenal, right celiac, posterior pancreaticoduodenal. At least 6 lymph node retrieved, improve staging and survival. Staging information in lymph node dissection, staging information and decreased local recurrence. Lymph node dissection, Sirani et al. Analyzed 2006 lymph node, 5-year survival, 81% in N0, 62% 1 positive lymph node, 43% 2 to 3 positive lymph node, 15% 4 or more positive lymph node. According to this study, the location of node was not significant.
Is this in the incidental carcinoma or in gallbladder carcinoma per se?
Incidental, maybe sir, resection may actually sir, N1 N2 is.
You get the same survival in re-resection as you get in the primary.
Yes sir, not very different sir, not significant sir, if operated in early in tertiary care setting.
Anil, when will you not operate this patient? After how much interval you will decide there's no point operating this patient? After how, suppose patient comes to you after 8 months, he underwent lap cholecystectomy 8 months back and he's come to you today. Will you still do a completion cholecystectomy in this patient?
No sir.
So
Sir,
after how much time you will not do a completion cholecystectomy?
Or it has nothing to do with time but has to do everything with the stage?
Yes sir, everything with stage. Sir, always re-stage tumor.
Take it as T1B tumor, which has come
Yes,
to
sir.
you 8 months after surgery or say 4 months after surgery.
Yes, sir.
Which one will you operate and which one will you not operate?
Sir, I go first for re-staging, sir, in any patient, sir.
It's
presented.
and I mean on your imaging it's N0 and M0.
After re-staging is and if no mets present, I went for surgery, sir.
Even if the patients come after 8 months?
Sir, sir, if re-staging is performed, CT, MRI, and PET CT.
Anil, you are not understanding. You're not understanding what I'm saying. If the patient has gotten operated in January and comes to you in say October,
yes,
and
sir.
second scenario is patient gotten operated in January and comes to you in March or April. So which one will you, I mean, are you going to operate both these patients, or you're going to operate one and not operate the other one, or you're not going to operate both?
Clinically and radiologically, if tumor is operable.
Clinically and radiologically, there is no disease except for the post-op specimen which has T1B disease.
Yes, sir. So then, sir, only lymphadenectomy. Actually, sir, T1B lesion, only lymph node is positive, sir. And near about, sir, muscle invasion. After muscle invasion, only lymph node is.
But 1 साल बाद patient आएगा, you will still operate.
Yes, sir. If re-staging is done and no metastasis is present, sir.
Yes, sir. And madam, I don't know. I think it's according to me, what I know is the timeline is 6 months. After 6 months, there is no point operating such patients.
So jury is not yet out on this, and that's why there is a thing that it should be stage driven. So if it comes, it's like T1B, I may not, but if it is a T2 lesion and still with no meds, I would give it a benefit of doubt if the patient is young and with a reasonable life expectancy. Okay, proceed please. तुमने क्या किया है ना Anil, you have clubbed everything together, so it has become a, what should I say, a mess. You should have stuck to your incidental gallbladder, which was a very specific topic.
Bile duct resection and port side resection. Bile duct resection in positive margin of cystic duct et al. 2012.
No, it is not still over.
Port side
Please,
resection.
44 listen to me. What are the indications for bile duct resection in a patient with incidental and a normal upfront gallbladder cancer patient? When will you do a bile duct resection?
Ma'am, cystic duct margin, ma'am, positive, or any unresectable lymph node, ma'am, which is present near the porta, and we
only near the porta or in the hepatoduodenal ligament?
Hepatoduodenal and porta, ma'am.
Ma'am, usually bile duct is removed when there is contiguous involvement of the bile duct, or if there is a nodal other node which is involving the node. In those cases also we may have to remove the bile duct to get a lymph node cleared, and also if patient is having jaundice and not in the resectable cases, but sorry, ma'am, those are the two main indications.
Jaundice per se is not the indication. First is
No,
direct involvement, margin
no.
positive, and nodes. That is
Yes,
the
sir.
three I know. If there is anything else, I don't know.
There is a group of surgeons who routinely do a bile duct excision, CBD excision, to clear the portal. And
No,
epithelial
now we have
ligaments.
sufficient data to suggest prophylactic resection is no longer necessary to
There are
achieve.
still people who do it, and
Yeah, but
there is a published
good,
literature. There is a
good,
published
yeah.
literature on it also.
But yes, but a large body of literature suggests that it is not helpful. Nothing is absolute in medicine. You know?
There is no randomized trial so far.
Okay. What about port sites you are telling?
Maker et al. In 2012, total 114 patients selected, 69 port side resection done, 44 patients did not resect. Port side metastasis found in follow-up 19% of patient, and in which patient who have peritoneal recurrence.
Anil,
Yes.
the port site excision you're talking about, is it the port from where the gallbladder was retrieved or all the ports? So, I mean, if you know which port site the gallbladder was retrieved from, there is no point resecting that also?
What English have you written here? 69 port site resections, 44 patient did not. What is this?
Ma'am, 114 patients selected, ma'am. Which 69
underwent, so you have to frame your English, you know. 69 underwent port site resection and 44 did not. And what did you find? That port site metastasis?
In 19% in follow-up patient, ma'am. They also have, ma'am, peritoneum recurrence.
So what does it tell
All
you?
19%.
So what does this tell you? That port site metastasis is a what?
Not associated with survival. Ma'am, port site metastasis in patient having peritoneal recurrence.
Yes, so it is a marker of a systemic disease. It is usually not a localized incidence.
Incidence, yes, ma'am.
And that is why only one port, extraction port, some people suggest that, you know, we should extract, you should resect the extraction port. But then there is data, not sufficient data to support that. So what would you do if there is a localized port site recurrence? You have done a PET scan and everything, there is no peritoneal carcinomatosis. Everything is hunky-dory, and then there is only single port site mets. What will you do?
And then, ma'am, resection done, ma'am, for that.
Any third years? Isolated port site mets.
If my patient is presenting late only with a port site recurrence, I would consider for a systemic chemotherapy, then reassess, and then we can consider for resection if there is no distant disease or PET.
So that prophylactic port site excision not recommended because no survival. Adjuvant
अब वो भी तुमने उसमें BC क्या लिखा हुआ है? MC, BC ये सब क्या लिखते हो तुम? हाँ? What is this?
Ma'am, because
ऐसे लिखते हैं because?
Adjuvant neoadjuvant treatment. Adjuvant treatment helpful only in R1, R2 resection and positive node, and also in lymphovascular invasion. Neoadjuvant chemotherapy, locally advanced, node positive. Example, gemcitabine, cisplatin, gemcitabine, angiloplatin, gemcitabine, capecitabine. After neoadjuvant chemotherapy, 1/3 of the patient achieved R0 resection and also found increased overall survival. Unresectable oblique metastatic disease. In these patients, we do biopsy from distance. Example, celiac, aortocoval lymph node. Nodal metastasis beyond porta. Distant metastasis, extensive involvement of the porta hepatis causing jaundice or vascular displacement. Unresectable oblique metastatic disease. Continue. AMSI, MMR, tumor mutation burden should be performed on biopsy. MSI high, deficient MMR, tumor mutation burden high, more than 10 mutant per megabase pair, may benefit from PD-1 blockage, pembrolizumab. Entrectinib or larotrectinib may be used neurotrophic tyrosine kinase gene fusion positive patients. In follow-up, Imaging study every 6 months up to 2 years, annually up to 5 years, or as clinically indicated. Assessment of CEA, CA19 also as clinically indicated. It is important not to violate oncological principle during lab procedure. Perform an accurate preoperative diagnosis. Preserve the integrity of the gallbladder. Use endobag for the removal of the gallbladder. When in doubt, give up laparoscopic to open SS. Carefully inspect the gallbladder once extracted. Perform a histological examination. Desufflate the neuroperitoneum with the trocar in situ. During cholecystectomy, accidental opening of the gallbladder in 5 to 30% of cases. Incidental discovered cancer at cholecystectomy are common, and this is sufficient treatment for T1A, T1B and beyond extended radical cholecystectomy with in-block regional nodal dissection and bile dissection if margin positive. Distant nodal metastasis N2 is incurable, do not benefit from reoperation. Preoperative imaging and surgical staging is crucial because high incidence of metastatic disease.
When will you do a wedge resection and when will you do a segment 4B and 5 resection?
If ma'am T1B lesion and if invasion less than 2 centimeter, if invasion more than 2 centimeter and Glisson capsule involved or portal radical or biliary radical vascular invasion, then we go for radical hepatectomy.
So where is that becomes a very advanced stage? We are speaking of incidental gallbladder cancer. How come the portal radicals will be involved in incidental gallbladder cancer? Your topic is incidental, na?
Ma'am, T3
Patient has come to you after. So definition of definition of incidental gallbladder. Why is it important? Because it is for a suspected benign disease. So you actually, if you have a very big tumor mass, like we see in patients coming to our OPD with a mass and somebody has done a gallbladder surgery, so that becomes a missed gallbladder. That is truly not a incidental gallbladder cancer. Although you have some studies in literature that do include those advanced cancers, but frankly speaking, they are not. तुम्हारे पास कोई early patient आया gallbladder cancer लेके, so what will you do? Will you do a wedge resection or will you do a 4B and 5? There is no question of doing a right hepatectomy in that patient.
Ma'am, in T1B lesion, ma'am, only wedge resection is indicated, ma'am. Wedge resection and regional lymph node dissection. Beyond T2 to T4, ma'am, radical dissection in which central hepatectomy or beyond, ma'am, trisegmentectomy, right hepatectomy.
Well, what is the rationale of doing a radical cholecystectomy?
Yes.
What is the rationale of doing a radical cholecystectomy or taking a liver wedge with the gallbladder? Why do we?
Sir, in neck, especially sir, cirrhosa is gallbladder is in liver bed, sir. Gallbladder is not covered with the cirrhosa. So
it's a wrong
that
answer.
is, sir,
it's a wrong answer, Anil. What lies between the gallbladder and the liver surface? Hepatis is not between gallbladder and liver.
What are you speaking? Huh? What is porta-hepatis?
Ma'am, porta-hepatis is liver hilum, ma'am. Yeah.
हाँ तो
in neck
cross section में पूछ रहा है. He is asking you if you cut the gallbladder sagittally, what are the layers you encounter? Start from the mucosa upwards into the liver.
Mucosa, then lamina propria, ma'am, then muscle layer, then perimuscular connected fibro muscle BDC written, ma'am, fibromuscular layer. Glisson capsule वहाँ पे नहीं रहता, बेयर एरिया होता है वहाँ पे.
उस बेयर एरिया में क्या होता है?
So where do you find all these what is the venous drainage of gallbladder?
Cystic vein.
How many cystic veins are there and where do they drain?
Ma'am, 2 to 3 cystic vein and right portal vein. They drain right portal.
They drain in right portal.
Ma'am, yes, ma'am. Direct drainage in 10% cases, ma'am. Direct drainage is liver hepatic vein and cystic vein drain portal.
So why do you do a wedge resection in gallbladder cancer or a segment 4B and 5? Has it anything to do with this venous drainage?
Yes, ma'am. Ma'am, near about 10% cases, ma'am, without total invasion of the gallbladder wall. A metastasis can be seen in.
No, you don't
the
know.
liver,
You
ma'am.
any of the
And
third
that
years, please
area
tell.
also.
GB fossa found by 4B and segment 5. They actually have a gallbladder vein stage directly into the GB fossa, that is in the liver bed 4B and 5. To get a clearance, we take a 2 centimeter wedge, and that is the main reason for doing a wedge dissection. Vascular venous drainage, that's 2 centimeter 360-degree coverage.
Would you decide, I mean, the boundaries of segment 4B and 5?
Intraoperatively, we can trace the hepatic segmental artery distribution. We can ligate the pedicle and we can see the demarcation. Then we can go for the anatomical resection. Otherwise, we can see the we can take a 2 centimeter margin non-anatomical, which is normally
No, I'm
made
not
by
talking about I'm not talking about wedge dissection. I'm asking you, how will you do the marking of segment 4B and what?
for that we have to
Suppose you have intra-op ultrasound with you. What will you see? What will be the right margin? What will be the left margin? What will be the upper margin?
Anatomical resection, ma'am, we have to trace the pedicle, ma'am, the segmental distribution, where we ligate the.
Have you heard of
distribution.
right hepatic vein? What
ma'am.
divides segments?
How are the segments divided? What is the basis of segment? The classification based on segments.
Hepatic vein, which makes the conort segments into 8 segments. Based on the portal distribution, and the plane is made by the hepatic vein, but its distribution is made by the hepatic artery and the portal.
So what lies in between segment 5 and 6 of the liver? And what lies in between segment 4 and segment 3 of the liver?
And right hepatic vein.
Left hepatic vein, ma'am, between left
Yes,
portal,
ma'am. Right hepatic vein divides the segment 5 and 6, and also
so that
right
you have
hepatic
to
vein.
see right hepatic vein. You have to trace with a ultrasound. Then becomes your
Then, yes,
right
ma'am.
side
Then
margin.
yes,
Then
and then ma'am, middle hepatic vein, which divides between 4B and 5, and also 4A and the left hepatic vein divides.
but we have to take segment 4. So how we? So what is that fissure called? इसमें dissect करेंगे
Yes,
जाके.
ma'am. Yes, ma'am. Yes, ma'am. That is the umbilical fissure, which divides segment 4B and segment 3.
So that becomes your other margin. Then how
Yes,
will you
ma'am.
decide your top margin?
Combination
So
of junction of right hepatic and middle hepatic.
Junction of right hepatic, middle hepatic.
Before they
They
join
all
the-
go and they join. They join the IVC right up. So
Yes,
how
ma'am.
does it matter? I'm asking about the transverse plane. तरुण पूछो भाई इन लोग से. What is the transverse plane?
अपर एक्सटेंड क्या है?
Either
अपर मतलब नीचे का तो फ्री बॉर्डर है, राइट लेफ्ट आपने बता दिया, अब ऊपर कितना जाना है?
see you have an ultrasound with you.
Portal vein, madam. Right and left portal vein.
Right.
Yeah, so that you can see on the ultrasound, the portal plane actually, you should say. What are the indications of doing a hepatopancreatic or duodenectomy in advanced gallbladder cancer? Is it done? What is the data? Third years I'm asking. अभी करते हैं नहीं करते हैं?
Usually locally advanced, if there is involvement of the duodenum by the gallbladder, it can be done. But since it's a highly morbid surgery, nowadays neoadjuvant chemotherapy is recommended, where we can avoid highly morbid surgeries like combined hepatopancreatic.
Answer
Still
would
done.
be that it is still done,
Still
but
done,
in
still
a
done.
very carefully selected group of fit patients after neoadjuvant therapy. Because even the most well-known surgeons from Korea and all Japanese surgeons, they have reported data that the impact on survival is offset by the high morbidity and mortality of the procedure. So patient selection is mandatory. Dr. Pandey, do you have any questions? You can shoot.
Nothing. I didn't get my answer actually.
आप बता दीजिए, please.
Oh, actually, the subserosal layer of the gallbladder basically consists of an inner and outer layer. Between the two runs the vascular and lymphatic plexus. So the purpose of taking out the wedge of the liver is that you do not disrupt the subserosal layer in the gallbladder on the hepatic side or the gallbladder bed. If you disrupt it, the chances of lymphatic and vascular invasion are higher.
But there are studies that say that even on table, if there is a high suspicion of CAGB, you can do a cholecystectomy and do a frozen section. And if it is positive, go back and do a radical chole, and the outcomes are not different.
That's true. That's
How-
true. But basically, it depends upon which side the lesion is. If the lesion is on the peritoneal side,
No,
then
but
there is no
those
problem.
studies do not mention about whether it is on the hepatic side or tumor
Yeah.
side.
And on the
On
hepatic
table,
side,
उसी
if
वक्त
the,
अगर कर दिया, then they say that nothing, it's okay.
yeah. And in patients where there is an inflammation associated, the subserosa become thickened.
Mhm.
And in most of these, this plane is then gets obliterated. This is actually the plane where you dissect in a normal simple cholecystectomy.
Yes, subserosal plate.
Subserosal plane. The purpose basically when they recommend that it should be and block hepatic resection is that you should not disrupt this plane.
Okay, one last question. Is there any role of minimally invasive surgery in gallbladder cancer?
Minimally invasive surgery is being tried now in many case series in Japan, and even in few Indian series also is being showed. But still a prospective randomized trial is yet to be done to show its benefit.
Yes, it has been done, and the proponents find that the lymphadenectomy actually is easier when done through minimal access. So far nobody has been able to demonstrate any advantage or disadvantage.